After my talk at SMACC, there were some questions about how to get better quality EKGs in the pre-hospital setting. So I took some of the slides that I used in the STEMI training as part of my research that I presented at SMACC, and I put them together here just to answer that quick question about how do you get better quality EKGs in the pre-hospital setting. There's three parts to acquiring the 12 lead. There's the skin prep, the electrode placement, and cable management. We'll start by talking about skin prep. So every patient needs some degree of skin prep. There's three main parts. For men, they probably need to be shaved. I've never seen a woman that needs to be shaved. That doesn't mean they don't exist, but most men are going to need to be shaved in order for the big circular foam electrodes that are typically used by EMS, in order for those to get any sort of good connection. Every patient, man or woman, should be wiped with a washcloth just really quickly to try and get off some of the oils and other stuff that's on their skin so the electrode can make better contact. Especially if you've just shaved them, then you need to wipe to get all the little bits of hair off. Last thing, do not, I repeat, do not pre-attach your electrodes to your monitor. Doing this, you might save a few seconds because you don't want to snap them on when you're putting them on the patient, but the long-term ramification is that they're going to sit in your monitor bag and probably dry out before the next time you run a 12 lead, and then they're not going to stick, or you're going to get a really bad-looking EKG tracing. And then you'd have to replace them anyway and put on new ones, and you've wasted a bunch of time. So don't pre-attach your electrodes to the monitor. Acquiring the 12 lead. Next part, we're going to look at electrode placement. So two big problems that often happen with placement of the electrodes. The first one, putting the limb leads on the chest. So you've probably seen that instead of being out on the arms or legs, they're attached to the chest. That can create or mask ST segment changes, which is a lot of what we're concerned with. And also the precordial leads, if they're off by more than 2 centimeters, about slightly less than an inch, can create or mask ST segment changes. So what I'm getting at here is that accuracy in your lead placement absolutely counts. So where do we put our leads? V1 and V2, fourth intercostal space on either side of the sternum. Then you're going to put on V4 in the fifth intercostal space, mid-clavicular line, V3 between the two, V6 mid-axillary line, V5 between 4 and 6 or at the anteroaxillary line. Worth noting that 4, 5, and 6 should be in the same horizontal plane. You don't need to follow the rib interspace going up, as it will. Just go straight across. So 4, 5, and 6 should be in a straight line perpendicular to the sternum. And your limb leads need to be on the limbs. Now, they don't need to be all the way distal out on the limbs, not necessarily at the wrists and ankles, but anywhere past where the deltoid inserts on the arms or anywhere past the inguinal ligament on the legs is good enough. So you can stay fairly proximal, but still have them on the limbs so you're not creating any of those problems with ST segment changes, but you're still reducing the amount of artifact that you get. Also worth noting, everything that I've talked about here is a bony landmark. This has nothing to do with surface or soft tissues. So in terms of pearls for improving your electrode placement, you need to palpate your bony landmarks every single time that you put electrodes on someone. So for the precordial leads, the one you're going to be looking at mostly is the angle of Louis. This is where the manubrium joins the sternum. You can palpate it by running your finger up and down midline on the upper part of the patient's chest, and you'll feel a little bump there. And that's where the second rib joins the sternum. So if you feel that bump, and then you come laterally and down a little bit, your finger will fall into a little space. That's your second intercostal space. Then you feel down 3, 4, then you're in the fourth intercostal space. You can place V1 and V2, and the rest based off of that. If you're having trouble locating the angle of Louis on the patient, it's roughly going to be 3 fingers down from the sternal notch. So if you have 3 of the patient's fingers, not necessarily your own fingers, but if you're the same size, you can assume that they're similar. 3 of the patient's finger with the top of one finger lining up the bottom of the sternal notch, you'll find that the bottom of the third finger is basically right on top of the angle of Louis. And so you can use that to kind of home in on where it should be, and sometimes they can help you feel it. Remember that the clavicle extends all the way to the end of the shoulder. So when you're finding the midclavicular line, it's probably going to be more lateral than you would normally eyeball it just by guessing. So let's talk about what to do with breasts. Based off the literature review that we did for this study and trying to determine what we should do, our recommendation is to put the electrodes directly on the breast because it's all about the bones, not about the soft tissue. Putting it on the breast doesn't increase the amount of artifact, it doesn't reduce the level of the signal, it doesn't do anything to the technical quality of the EKG. So we say by default go on the breast. Now if you can move the breast aside and you'd be able to put the electrode directly on the chest wall in the correct position, then it's reasonable to go for that, but there isn't necessarily a reason to. One of the other reasons that came up in the literature review that we suggest going on the breast rather than under, there's at least one study that was looking at how do women feel when they have electrodes placed on the breast versus under the breast. And in this study, they found that women they preferred on the breast placement, presumably because it involved less manipulation of the breast and made the procedure feel less invasive. Another advantage to going on the breast rather than under, let's say that you arrive on scene and you're in an office or something, the patient's in their cubicle having chest pain, you want to get a 12 lead right away, but it's going to take a while to get them on the stretcher, get to the elevator, get out to the rig where you could have them remove their clothing to get under the breast and do all that. So if you go on the breast, you can reasonably feed the electrodes down the top of their shirt, get them in position, and get the 12-lead EKG right there much earlier and potentially change their management versus waiting until you get them into a place where it's private enough to have them disrobe and do the under the breast placement. So my feeling is not only do women seem to prefer this placement, but you can potentially also get your EKG earlier in the encounter, which is going to be important for managing and diagnosing the patient. So the last tip, I'll talk about cable management. So you're probably familiar with this, the cable that's used, it's the monitor. All of the artifact that you get from cable movement occurs between this box here and the electrodes where they're attached to the patient. That's where all of the artifact is generated. Any movement of this big thick cable that goes between this bulge and the monitor, that cable movement does not contribute to the artifact. You could play hula hoop, you could play jump rope with that, and it wouldn't contribute to the artifact on the EKG. So if you take this box and move it to the stretcher so that this is stationary relative to the patient and let this hang across over to your monitor, the big thick cable, that'll reduce the artifact. What I see a lot of medics doing is they pull the electrodes out. This is somewhere in the middle between the monitor and the patient, and these are sort of dangling over. And that's where you get a lot of that artifact when you're in transport. So my recommendation is move the box to the patient so that all the cables are moving with the patient and that only this big thick cable is swaying around, and that'll reduce your artifact markedly. So I'll just finish up by showing this EKG. This is a decent quality EKG, pretty readable, but I just want to point out that this was done while someone was walking on a treadmill at 2.5 miles an hour up a 12% incline during a cardiac stress test. So you can very reasonably get an EKG not only while someone is walking on a treadmill using the things that I've outlined here, but you can certainly get it on a patient that's laying down supine in a moving ambulance. So if you follow some of the take-home points here, I know you can get good EKGs in the pre-hospital setting. So remember, always prep the skin. Don't pre-connect your electrodes. Always palpate the bony landmarks for your electrodes. Remember angle Louis. Move the box to the patient so that the big cable is the one moving, not the little ones, and you should have less artifact. And that's it. Thanks.